Our clinical challenge is isolating this exact pathology from the dozens of other conditions that cause undifferentiated abdominal pain. To do this reliably, we use a 4-step diagnostic checklist: symptom assessment, physical exam, a specific laboratory panel, and finally the imaging pathway. By working through these steps methodically, you can secure a definitive diagnosis or safely rule appendicitis out. Step 1 is evaluating the patient's history. We are looking for a highly specific chronological presentation known as Murphy's syndrome. This syndrome unfolds in a 3-part sequence. First, the patient experiences the onset of pain. This is followed by vomiting, and finally, an elevated temperature. Pay close attention to how that pain travels. Typically, it starts in the midline as a dull, visceral ache before shifting downward to the right iliac fossa, where it becomes a sharp, localized parietal pain. But there's an anatomy trap. This diagram illustrates appendix positions dictating where patients feel pain. Over 65% are retrocolic, behind the cecum, causing back or flank pain. Alternatively, a pelvic appendix at 4 o'clock causes diarrhea, easily misleading clinicians. Because these anatomical variations are common, your history taking must account for presentations that deviate from the textbook midline to right side pain. Once the history is recorded, step 2 is the physical exam. We start by palpating McBurney's point in the right lower quadrant to check for localized tenderness. Next, we perform the Rofsing sign. By pressing firmly on the patient's left lower abdomen, we look for referred pain on the right side, indicating localized peritoneal irritation. We also test the obturator sign. By internally rotating the patient's right hip, we can trigger pain if an inflamed appendix is resting against the obturator internus muscle. The psoas sign operates similarly. The patient lifts their right thigh against resistance. Resulting pain suggests the appendix is irritating the psoas muscle. During palpation, you must also be alert for advanced pathology. A palpable lump in the lower right quadrant suggests an abscess has already formed, while a board-like rigidity of the entire abdomen points to peritonitis following a perforation. These mechanical maneuvers are designed to physically provoke the parietal pain we discussed in step 1, moving our assessment from the patient's subjective history to an objective clinical finding. Step 3 brings in the laboratory panel. The goal here is twofold: secure biochemical confirmation of the infection and definitively rule out life-threatening mimics. First, you must order an HCG pregnancy test for all women of childbearing age. This is an absolute requirement to rule out an ectopic pregnancy, which presents with near-identical symptoms. We also run a urinalysis to check for bladder infections or kidney stones, clearing other common causes of lower abdominal pain. With mimics cleared, we look at this table, detailing the triple screen, our core diagnostic metric. We are evaluating white blood cells, neutrophils, and C-reactive protein. We are looking for elevated white blood cells overall and a CRP over 10 milligrams per liter. Crucially, we also check for a left shift in the neutrophil count, meaning neutrophils make up more than 75% of the total white blood cells. If all 3 of these markers are elevated simultaneously, the probability of acute appendicitis jumps to between 95 and 99%. This lab panel acts as a highly accurate gatekeeper. It dictates whether we hold for observation or proceed to step 4 for definitive radiological imaging. Step 4 is selecting the correct imaging modality to get physical proof of the inflamed appendix. This flowchart breaks down the master decision tree for imaging. For pediatric and pregnant patients, we prioritize abdominal ultrasound to eliminate radiation exposure. For non-pregnant adults, or if the ultrasound is inconclusive, the pathway directs us to a contrast-enhanced CT. As seen in this CT scan, we look for specific radiological markers. We are checking for an appendiceal wall thicker than 3 millimeters, the calcified blockage of an appendiculith, or structural signs of inflammation, like the arrowhead and sequel bar signs highlighted here. Selecting the correct imaging modality based on the patient profile provides the definitive anatomical proof the surgical team needs to operate. We have mapped the initial migration of pain, mechanically provoked it during the physical exam, verified the biochemistry with the triple screen, and finally secured our radiological proof. You are now equipped to navigate this clinical pathway, identifying the infection well before it reaches the critical stages of perforation and sepsis. By applying this structured protocol to every case of undifferentiated abdominal pain, you ensure a fast, accurate, and safe diagnosis.